and his presence here. We thank you for Tony. We thank you, Lord, for the professionalism that's going to come forth. We ask, Lord, for those who are listening, Lord, that they will be fed by what is said today. And we pray that change and transformation take place during this time. In Jesus' name we pray. Amen.
Wow, beautiful. Good day.
Listen.
How are you?
Amen.
What's up?
We can talk about it. We ain't passing no judgment. Don't be ashamed. It's all
How are
the
you?
same. Stay in your lane. Your lane. It's whatever your real life looks like. Stay in your lane. Come out the dark and don't be ashamed. Your lane. Let's have a conversation on what we face every day. Tune into your lane talk show. It makes us feel good just to know we're not alone. No more we've been isolated and cast aside. I want you to come out the dark. Just don't be afraid of your heart. So don't be ashamed. It's all the same. Stay in your lane. Your lane. It's whatever your real life looks like. Stay in your lane.
Great song.
Great song. Your lane. Let's have a conversation on what we face every day. It's your Lane Talk Show with Coach Trish Hanna.
Hello, 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 and welcome everyone to Your Lane Talk Show with your coach, Trish Hanna, broadcasting live from the beautiful Nassau, Bahamas. It's hot today, isn't it? It was hot last week too, but today just feels worse. I don't know what's going on. Last week it was like 91 degrees when I came in. I think now, I don't know if it's, but yeah, I don't know how much it is now. Tony, you know? You don't know it. We don't know. We'll get back to you on that. But for those who are listening to us for the first time, thank you so much for joining in and tuning in today. Your Lane Talk Show was created to educate, encourage, and empower women of all ages. And we talk about everything. I mean, every single thing from relationships to health to beauty to fitness, you name it, we have it under control. All right. So last week, our previous show, we had with us Apostle Gerald Benton from Atlanta, Georgia. And he taught under the topic, Teach Me. Well, he spoke, not he. Yeah. He spoke under the topic, Teach Me How to Love Him. Wasn't that a phenomenal show, Adessa? Oh my God, that was so awesome. To this day, people are still reaching out to me about how wonderful the show has been and how impactful the gentleman was who I had. And listen, salute to you, Apostle. Thank you so much for your input and what you've done. Listen, when he spoke about, well, it's episode 60 for those who want to watch it, to be honest. You can go on YouTube, Coach Trish Hanna, episode 60, Teach Me How to Love Him. But Apostle Benton spoke about how he was, mischievous as a husband. He walked out on his wife, three times? Three times. He was addicted to drugs, addicted to alcohol. And his wife prayed him back to health or deliverance. He spoke so highly of her. The entire show was basically, if you were to put it in a nutshell or sum it all up, was for wives who are tuning in. Listen, no matter however you see your husband, whatever condition he may be in at the moment, all you need to do is go to the creator, the person who created him, and say, Daddy, look, I need you to fix it. Fix it, sir. And in most cases, you know what Daddy does? He fixes you. He comes to you and say, okay, I'm going to give you the grace that you need. And while I'm working on you, I'll work on him. But your posture is through me first, and then I'll deal with your spouse. So that was really awesome and encouraging for those who were going through or still going through matters regarding their marital relationship. All right. So now, because without further ado, we want to get this going, man. We want to get this going. I want you to call someone who you know may be experiencing issues when it comes to fibroids. And for people, every woman that you know, because there are some who may not even know they have fibroids. They may have some symptoms and may try to ignore it or just think, oh, it is regular. My Grammy had, heavy menses. And so my mommy had heavy menses. So I have heavy menses. So there ain't nothing wrong with that. That's fine. I'm only saying this because I'm not the doctor. He'll tell me if this is regular or normal or not. But I'm telling you, call a friend, call a sister, call a neighbor, tell them tune in. We're live now on Star 106.5 FM dial. You can also watch us on Your Lane Life Coaching Facebook page. You have an opportunity to see who this guest is for today. And you can also log on to Star 106 FM on Facebook as well. My predictions for this episode is 100% aha moments. I don't see any teardrops at all. None. And definitely, maybe, no, let's say 99% aha moments, 1% laughter.
1%.
One.
Yeah.
One, because the guest that we have is more, what's the word I want to use? He's reserved. Is that the word I should use, Tony? He's not that comical, but he could be. Yeah, he's more on the serious side. But you never know. Something might spring up. We just never know. All right. So you're lean, episode 61, uterine fibroids, causes, symptoms, and treatments. Brought to you by Airborne Freight and Cargo Services, John Shoe Store and Accessories, Your Lane Life Coaching, Bahama Odds and Ends Party Supplies, Johnson & Johnson distributed by Lowe's Wholesale, Carey's Fabric and Uniform Store, and Dairy Queen, Bahamas. Carey's Fabric and Uniform Store is stocked with uniform fabrics and ready-made school uniforms for almost every school in the Bahamas. At Carey's, you'll find uniform skirts, jumpers, shirts, blouses, pants, shorts, underwear, and school supplies. You can get your skirts custom made if you don't have someone. You can go right down to Mackey Street, that's where they're located, and shop at Carey's Fabric and Uniform Store. The number to call there is 3930758. That's 3930758. Shop early and save. Buy a blizzard and make miracles happen. Join Dairy Queen this Thursday, July 27th for Miracle Treat Day at Dairy Queen locations, all of the Dairy Queen locations nationwide. For every blizzard, treat, or coupon purchased, you get $2 that will be donated to the Bahamas Kidney Foundation. So they're donating $2 for every blizzard, every coupon purchased from any one of their locations. Dairy Queen, together, let's make a difference for those in need. Summer is here. Grab your Johnson & Johnson skincare. This summer, during the month of July, this is the final month for this, of course, purchase $15 or more of any Aveeno, Neutrogena, and Clean & Clear products and enter to win one of 3 amazing prizes: a $500 travel voucher, a $250 John Bull gift card, or a $100 Visa gift card. You can pop into any one of the Lowe's pharmacies or other participating retailers. Promo ends July 31st. I'm wishing you all the blessings, hoping that it's you who's listening to receive those prizes. Now, let's get in and on to our guest. I would like to introduce to you Dr. Mikhail Higgins. Dr. Mikhail Higgins is a native of Nassau, Bahamas, having graduated from Queens College, where he was Senior Track Athlete of the Year, Gentleman of the Year, and valedictorian for the Alpha Phi Alpha Honors Day Convocation. Over the past 6 years, he has served as an assistant professor in the Department of Radiology at Boston Medical Center and Boston University School of Medicine. He is the former director of medical student education for the Department of Radiology and the former program director for the Early Specialization in Interventional Radiology program. He is the vice chair of the American College of Radiology's Appropriateness Criteria Interventional Radiology 2 expert panel. I hope I said that correctly. He is the chair of the Diversity, Equity, and Inclusion of Advisory Group for the Society of Interventional Radiology. He is the founding chair of the RISQCS, the Radiology Intervention Safety, Quality, and Complications Symposium, a global continuing medical education meeting which has been endorsed by the Society of Interventional Radiology. As an interventional radiologist, he is an expert in minimally invasive treatment for uterine fibroids and uterine adenomyosis, 2 conditions that plague women in the Bahamas, the Caribbean, and across the globe. He is the first fellowship-trained, board-certified interventional radiologist in the Bahamas and has treated and cured scores of women across our archipelago using his minimally invasive uterine artery embolization technique, a procedure that was pioneered in France in 1995 and has since been used to cure hundreds of women across the globe without the need for major surgery. I have you to know, I want a round of applause for not cussing or speaking in tongues while I was reading Dr. Higgins' profile. Thank you so much. Dr. Higgins, welcome to your Lane Talk Show. How are you today?
I'm doing fantastically well. Thank
It
you,
is
Coach
so
Trish.
nice to have you,
I
sir.
appreciate you. I'm so humble and grateful for your invitation.
I'm humbled that you accepted it.
Thank you.
All right. So now, just to break the ice, sir. Now, we went to a particular school together at some point, and you were the smartest person in the school,
It's very
right?
kind of you.
Don't act modest today. You were the smartest person in the entire school. So I want to know, sir, has being a doctor always been in your mind? Has that always been your profession of desire?
So interestingly enough, which we sort of discussed before, I'm a younger brother. My older brother is 4 years, 6 months, my senior. And I was a traditional snotty-nosed younger brother who just followed my brother around, kind of did what he did, went to the parties he went to. And I sort of kind of really looked up to him. And so, when he decided, he's like, I want to be a scientist. I'm like, yo, I want to be a scientist too. And then one day he was like, I don't want to be a scientist anymore. I want to be a professional athlete. And I was like, okay, I want to be a professional athlete too. And then one day he said, you know what, actually, I want to be a doctor. And then he just stopped there. And I was like, I guess I want to be a doctor too. So that's sort of how I actually ended up sort of transitioning to this sort of focus on being a physician. It was actually my mother who was like, you know what? I think you definitely have it in you to be a doctor, but I think you should probably really sort of evaluate this, explore this journey just a little bit more. So my brother actually went to the University of West Indies, the University of West Indies in Mona. Amazing education, did it at advanced levels at Queen's College. And then subsequent to that, he was a doctor at 23 and, did his training in the US, residency and fellowship training. That was sort of a very direct route, very resolved, definitive, decisive sort of route. Whereas my mother said, I don't know if you can just go to UE and you going to be sort of happy with your decision. How about we sort of let you, explore a bachelor's degree. And maybe, at the end, if you still want to do medicine, we support you. And so sort of she allowed me to go to the US to pursue my bachelor's degree. And I did pre-med. And ultimately I found it in myself that this was sort of the field for me. They say, I remember there was a young lady, where I did my master's, Vali Kouar. She was at Yale Law School, and she said, your calling is where your blessings, your gifts meet the needs of the world.
Mm-hmm.
Okay. Mm-hmm. And for me, I realized that my blessings, my gifts met the needs of the world in being a physician. And certainly what we're talking about today is where that sort of intersection is actually sort of meeting home for me, which we'll sort of dive into.
Mm-hmm. Wow. So you followed in your big brother's
Big brother. He's not big anymore.
So,
but yeah. I'm a
so
little
that means
now.
If he wanted to be a chef, then you probably would have been a chef.
Probably. We wouldn't be having this conversation today. Yeah, there you go. That's how it works.
Right. So why a radiologist? I mean, out of all the different things to become as a doctor.
Yeah, so that's a great question. So the first thing I'll do is I'll sort of clarify. So I'm not a radiologist. So when you think about a radiologist is a diagnostic radiologist,
right? Which
is a person who looks at imaging for the means of interpreting some form of imaging, whether that be an X-ray, an ultrasound, an MRI, and that's purely for diagnostic purposes. Okay, that has been around for many years. Okay. Mm-hmm. Now, interventional radiology is actually a new field that was developed in 1964. And what it is using image-guided procedures to address common medical conditions as non-surgical alternatives to their care. Okay. And so what I use those same modalities, ultrasound. So I'm an expert in ultrasound. I'm an expert in CAT scans. I'm an expert in live X-ray. I'm an expert in MRI. And I use those modalities to guide procedures to make them less invasive. So I did the same training as a diagnostic radiologist, and then I did additional training. So just to sort of answer your question. So why interventional radiology? It's so funny. When I was there in the Bahamas, I was graduating, so I transitioned from where we met, the first school, St. John's College, and I transitioned to Queen's College, where I subsequently graduated from. And right before I left, and I spent a year at the College of the Bahamas, there was a doctor who said, I said, well, what would be a great field, to go into? And I remember he said to me, and he didn't even bat an eye. He said, interventional radiology. I said, what? I said, what is that? Is there anybody here in the Bahamas that could shout? He said, no. He said, that's why I'm suggesting that you do it. I said, well, what do you mean? He said, what is it? He said, first of all, imagine your ability to get to anywhere in the body without surgery. I said, how is that possible? He said, don't worry about it. He said, between you and I don't even understand it either. I said, but I just know it's a thing. Yeah. And I said, well, tell me a little bit more. He said, you think about strokes. I said, well, wouldn't you have to cut somebody open? And he said, no. They go in through the blood vessels and they pull out the clots. I said, unbelievable. I said, well, he said, when you think about tumors, surgery, cut somebody. He said, no. These guys go in, they find a blood supply to tumors and they block it off. Or they go through the skin, through a little tiny incision, and they put probes in it and freeze them or burn them. And I said, what? And he said, and so imagine you got a gunshot wound right now. He said, what do you think you're going to do? He said, oh, you go to surgery, they go cut me open. He said, no. Those guys, they go in to the blood vessels that are leaking, and then they basically coil them off or embolize those vessels. He said, no surgery necessary, unless obviously the surgery is needed in other parts of the body. And I said, wow. And he said, and there's nobody that I could shadow in the Bahamas. He said, no. He said, that's why I'm telling you to do it. And I remember him, and we had that conversation. I remember exactly where I was. We were on Augusta Street, and we were having a chat. And when I got to medical school, one of the seniors there, I was a first year medical school student, and the senior said to me, he said, most people come to medical school wanting to do a particular thing, and they just follow that pathway until they graduate, right? Either maybe they have somebody that was particularly influential in their community. For me, when I came to medical school, there were people, a few super influential clinicians in my life. One was an anesthesiologist, Dr. Mark Weish. He was just an exceptional clinician. The other one was Dr. Dwayne Sands, a cardiothoracic surgeon. I shadowed actually along with my colleague, my co-student, classmate rather, at Queen's College, Dr. April McGive, who's not an anesthesiologist. She and I, we did three days, our career day at Queen's College with Dr. Weish. And then during that time, shadowed Dr. Dwayne Sands, and I was just so awed by what Dr. Dwayne Sands was doing. And then the other person was Dr. Perry Gomez, so obviously being an HIV specialist. And so those three people, for me, were just like the cat's meow as it relates to sort of clinicians. So going into the medical school, those are the people, HIV, specialists in infectious disease, thinking about cardiothoracic surgery, thinking about anesthesiology. But this person said, so you like many people may feel inclined to do these things because of these people who were so influential, just being beacons in your community. He said, but what I would encourage you to do is, in order to prove a hypothesis, sometimes you have to figure out why this hypothesis could be disproved, right? So if you think that you really want to do something, why don't you explore other things first to see if you don't like those other things or if you do. And I said, that's a strange way to look at it. I said, well, what do you suggest? He said, well, I would sort of say to you that there are very many people who I sort of see go through medical school and they get exposed to certain sort of specialties. And at the end of that time, they're like, wow, I wish I had gotten exposed to this earlier, because some of these are super competitive. And so you can't just get exposed and figure out that you could just jump in and apply and they're going to take you. Right. And I said, well, what are those specialties? So he listed a few, which maybe some people have never heard about: physical medicine and rehabilitation, radiation oncology, interventional radiology, and then of course plastics and urology and ophthalmology were others. And so he said I would suggest that you shadow a few people and sort of really get a feel for what it is that they're doing and let them sell their field to you, and see if you like not only the field but the people in the field. And I said, that's interesting. He said, because, medicine is just as tribal as any other, industry. And so I said, okay, cool. So I shadowed an interventional radiologist. And what I appreciated was the following: not only how he was just a great person, as my Jewish friend says, he was a mensch. He was just a good human. You could feel him through and through, just like a solid human, very intelligent, cared about people. And I could feel it from my interaction with him. At the time I had dreadlocks. And and he looked at me and he said he was just so happy to see me in his office, little guy from the Bahamas with dreadlocks. And so he then took me down to the interventional suite, and I walked down, and the first person I saw was a woman who had varicose veins. She was a model. She was coming in to get sclerotherapy, where we would put injections of little sclerosins to basically collapse the veins so that they could then escape to the deeper veins so you don't see them. Right. So she was getting this cosmetic procedure, what we do. I walked into another room, a little baby who had a lymphatic malformation in his neck, very much disfigured. Another interventional radiologist was actually injecting a similar type of substance in order to basically sclerose the lymphatic malformation in order to heal this so that the baby wouldn't be disfigured anymore. Walked into another room. Another interventional radiologist was treating a tumor in the liver, a patient that had a hepatocellular carcinoma, which is a primary tumor of the liver, and basically blocking off the blood supply from the inside, little tiny incision in the groin, Band-Aid surgery, in order to downsize this tumor as a curative measure. And then the fourth person was actually a bleed, a gastrointestinal bleed. Gastrointestinal bleed that they went in endoscopically in order to treat from above, through the throat into the stomach, and they couldn't sort of see the bleeding. It was bleeding too profusely, and so the interventional radiologist was basically coiling off the major vessel to that particular site. So in 4 rooms, I saw a pediatric patient, a model, a cosmetic procedure, a cancer patient, and then, of course, a patient who was in extremis, who was bleeding out. And so I said, boom. I said, I love medicine. I love every system. I love all patients. I love little babies and even more little old ladies. Okay. And I said, and I could treat them all, and I don't have to sort of stay with a patient population, and I get to enjoy what it is that I do in a minimally invasive fashion, in a way where I can provide non-surgical alternatives to common medical conditions. And so for that was it. That was sort of love at first sight.
So you do all of that?
I do all of that. And so in my capacity over the past, since I've been practicing, IR since 2013, that's what we do, and sort of in the Bahamas, again, as we'll sort of get into, when I started offering these services, 2 years ago, I started offering sort of to scale them over time.
Right.
And I started with a needs assessment. That needs assessment to what it is led me to sort of really offer a service that I felt based on that needs assessment was what the people needed, not what I thought I wanted to do, which I, at the time enjoyed doing many other things, but I wanted to offer what I felt the people were in need of. And that's why I'm here.
So that eliminates my first 2 questions there. All right, because that's awesome. Because one of the questions is, what exactly is the interventional radiologist and what they do? And that, I'm so glad that you answered that. That's beautiful.
Yeah.
And so this is just one other question to break the ice, because we will get straight into uterine fibroids. What were some of the challenges? Give me two challenges that you may have faced from where you were, in college, et cetera, to where you are now. And you can think of any 2.
Yeah, so just challenges in general.
Well,
how much time you got, man? How much time you got?
Even as far as practicing medicine here, doing your practice here. Whatever you want to share.
Yeah, so that's such a fantastic question, because for me, they say Winston Churchill say, success is moving from failure to failure without losing enthusiasm, and so I've really gained enthusiasm over time, because there've been a lot of failures, and a lot of them have been ones that have sort of led to great insights and great momentum, and so I'll sort of use one in the U.S. and then I'll sort of kind of focus on one here. So I think when you are practicing in an environment in the US, or any environment, part of it, you have to deal with disinformation. Okay. And that's something that I've experienced both in the US and here. Okay. You have sort of a competitive landscape where people are not necessarily there to sort of help people. Okay. And sometimes you sort of dealing with sort of disinformation as it relates to, obviously you go into, to receive a procedure, and you're sort of talking to someone about this procedure, and then the first thing the patient may say to you is, well, I heard that this is going to sort of kind of prevent me from sort of getting pregnant. They say, well, is this, where did you hear this? Well, I've heard this from other doctors, X, Y, and Z. And so I think the disinformation piece, sort of speaking out of turn, is something that I've sort of experienced, where patients sort of come in with sort of points that they've received from individuals that may not have been in a position to sort of share them, and having to sort of work backwards is something that I've sort of experienced, and you have to sort of meet that with grace, and you have to sort of meet that with humility, and that's been something that I've sort of struggled with, but in trying to ensure that when I'm talking to a patient, I always meet them where they are.
Right.
I always sort of address their concerns in a manner whereby I'm understanding sort of where it's coming from, so that at the end of the day, that they feel like they've been educated, they've been informed. In the Bahamas, the landscape is a little bit more competitive, partly because, for whatever reason, I've been met with sort of great collaborators who, people, they sort of see you come into the Bahamas and they say, well, what can I do to help you and to support you? And I just appreciate that. The level of disinformation sometimes has sort of been something that's been a little. I had a patient who walked into my office and she said, doc, I have a burning question. And I said, well, what's the burning question? She said, my doctor said to me, this procedure is not for Black women.
Wow.
And I said, wow. And of course, she told me the name of the physician. And I was saddened. And I said, well, and then the next question that she asked is, well, do you still want a referral to see him? And I said, well, she said, yes. I said, but I just told you it's not for Black women. She said, it's not going to work on you. She said, I think you should just move forward with the surgery now. She said, I appreciate that, but let me, can I just talk to him? She said, and she sort of discouraged the patient doing it. And the patient came to me and she said, thank you, Jesus, for telling me that. She said, because I believe that was not the case, but I've been with this person for so long. I trust her. And I said, I thought that was, she said, I thought that was something that was a little unsettling, and I just wanted to see you. And there's been other conversations like that with other patients where they say, well, why do you want to go to see someone with, who's doing something that's not going to work on you, or why are you going to do something where, you probably will never get pregnant again. And so that level of like active disinformation is something I'm like, wow, this is unfortunate.
Dr. Higgins, I'm glad that you're here because listen, we're going to dispel all the myths today, right?
I appreciate
We're going to do all that today. So what I'm going to do is I'm going to take a break. And when we get back over on the other side of the break, we're going to get straight into what we came here for. I just wanted to get Dr. Higgins little relaxed. I was being a little nosy too because I wanted to know what all the challenges were. But just so we could just break the ice and so we could get straight into the information that is needed for you all as you tune in. Thank you so much. And let's take a break, Tony. All right, to my Facebook audience, thank you so much for tuning in. We have with us in studio Dr. Mikhail Higgins. He is an interventional radiologist. And of course, to my right, you can't see her. I don't know why she's on the camera. She doesn't want to be on the camera. But you can hear her. That's Odessa. Y'all know that's my sidekick. That's my girl. That's my, if I have to go on vacation, I am comfortable enough to know that Odessa will come over, take the mic, and just do what she has to do. No questions asked. So, Dr. Higgins, this is
I was wondering. I was when you walked in, I wasn't sure if you were coming or staying. So I would introduce myself. I'm sorry. Odessa. You came right in and sat right down. So nice to meet you, Odessa.
She's on my side, just helping me whenever I need. One time last week, I don't mind. I can talk about this. Last week I was choking to death. Oh my God, my throat was dry. Everything was going on during the live.
Oh geez,
and so she was able to help me along with that, and she's been doing that for this past year, just helping whenever I need to. And if a guest needs, if you want to refill your water, or whatever.
Thank you.
Yeah, she should be able to assist. And she asks a lot of really good questions too. So when I may just take a break and say, "That's got anything to say?" And so she's phenomenal.
Yeah, awesome. Well, nice to meet you, Odessa.
Yeah. All right. So we have a question here from the Facebook audience. You want me to ask this now, or you want to wait till we get back?
Wait till we get
back.
Yeah.
You want to wait till we get back?
Yeah.
Okay. All right.
That sounds good. Awesome. Thank you for helping Coach Trish out, man.
My girl.
Yeah, man. It's good to roll deep like that, man.
Very few friends you meet along the way, and I keep very few, and she's one of them.
Yes. Well, listen. Love that. Love that.
Why everything's so quiet though? Everything's just.
Oh, that's the commercial. Okay, I was wondering. I'm like, where's the commercial? Okay.
I can't wait to talk to you. Please. That's still funny. That is still funny. I need to write another one though, and I get no dry. Yeah. Thank you.
To your lane
20.
with Coach Trish Hanna.
You pump it up?
Welcome back. For those who are joining us, we have with us interventional radiologist Dr. Mikhail Higgins in the building live in studio, along with Odessa Francis, who's just chilling along with me, and my producer today is Tony Williams, and we're excited because we are about to just dispel things that y'all have been saying. Oh, if I get this thing if I have fibroids and something happened to me, that's it. I can't have no more children. I can't do this. I can't do that. I've heard them all. And I can't wait to share my side of the story because I was also blessed to have this particular doctor do my, yes, I wouldn't say surgery. What do I call
Procedure.
it? Procedure. All right. So I'm going to talk a little bit about that at the end. All right. So with us in studio, Dr. Mikhail Higgins. Dr. Higgins, I want to find out from you, first of all, before we get into the major questions, because we have a few here. What is uterine fibroids?
Yeah, great question, Coach Trish. So first of all, a uterine fibroid is a benign tumor of the uterus, the womb. Okay. It actually comes from the word leiomyoma. So we actually call it fibroid. We also call it leiomyoma. So when you think about the word leiomyoma, it's sort of broken into two parts. So lyo is sort of muscle, oma is tumor. Okay, you put those together, muscular tumor. So it's a muscular tumor that's benign, it's non-cancerous, and it has some sort of kind of fibrotic elements in it as well. And it is sort of the most common benign tumor within the uterus. And obviously we can talk about why it's an issue. It's an issue because it really affects 80% of women globally. At least one point in a woman's life, she'll have one tumor, 80% of women. And usually women who are symptomatic are usually about 1 in 4 women. And unfortunately in the Caribbean, in the Bahamas, where we sit, we have obviously quite a bit of women of African descent with African heritage. And that is reason why that the number is actually so high, particularly in the Bahamas, where about 80% of women actually present with fibroids, many of which are symptomatic.
Too many. And what do you think caused the uterine fibroid?
Yeah, so that's another great question. So there's really, if you sort of think about why, there's the why is usually sort of the genetic predisposition. So if you're genetically predisposed, and it's funny, I was having dinner in Boston with a mentor and his old colleague from Belgium, and he said fibroids. Why have I heard this? And this was a gentleman, white gentleman, professor at Harvard, and he runs the Science of Human Past, and he said, I was just on a paper about fibroids, and I said, you want a paper about fibroids? He said, yeah. He said, oh, when he brings the paper out, and he said, oh, they had done the genetic genealogy related to fibroids in the Caribbean, showing the sort of genetic pool from West Africa that sort of led to sort of this genetic predisposition and preponderance here in the Caribbean and certainly also in the US. And that really comes obviously from the diaspora that we know, from obviously originating from West Africa. And so when you think about that genetic predisposition, that's why we have it. There are things that sort of cause fibroids to worsen, which certainly we can get into, and one of which is estrogen. Right. So estrogen, which is a lovely hormone that fluctuates on a monthly basis in women, it's sort of a symbol of femininity, and it sort of has highs and lows in a very sort of orchestrated fashion, like a well choreographed orchestra. But unfortunately, if it's sort of off balance, bad things happen. It's too high, too low, you obviously have different symptoms. But the presence of estrogen at a high level is like almost like fertilizer, for weeds. And so if you think about the fibroid as a weed in the uterus, estrogen will cause it to grow. And unfortunately, there are things when you think about estrogen, where estrogen's found, there are areas that people don't think about where estrogen's found. One of those areas is actually in fat cells. So you think about a place like the Bahamas, where obesity is not an issue that we take lightly here in the Bahamas, but it's something that is not uncommon when we think about it. And unfortunately, fat cells generate and produce estrogen. So when you think about obesity as an epidemic and you think about fibroids as an epidemic, they kind of go hand in hand, right? So the more obese you are, the more your fibroids are likely to grow, because the more fat cells, the more estrogen, and the more estrogen feeding those fibroids.
Wow. So that dispels that other questions. I wanted to know if it's genetic, but obviously we know that it is and it can be.
Yeah.
And so one of the questions that is asked here is your field, hold on, is that right? Field. Yeah. Are you able to diagnose cervical cancer?
In
your field?
Yeah. So as an interventional radiologist, we don't sort of do a lot of diagnosis. So diagnostic radiologists typically do the diagnosis. And again, obviously we're talking about fibroids today. And so cervical cancer is a completely different condition. It's a cancer of the cervix. And obviously cervical cancer, when you're sort of working with a gynecologist, they would typically do a pap smear. That pap smear and collecting those cells would sort of lead them to then identifying whether or not you have, malignant cells. So gynecologists would be the ones sort of providing the pathology for that. And certainly if you have a radiologist involved, if you get an MRI, they can obviously see, in some cases, cervical cancer, depending on how advanced it is. But it's not something that I focus on. And certainly something that's completely unrelated to fibroids. But an important question nonetheless.
Yeah, it's an important. Listen, my listeners, especially Yolanda, she's right on point. I mean, she could talk about the C, and I'll ask that question on today's show because she's so supportive. But if you want to call in and ask a question, you can do so at 328-8164. That's 328-8164. Dr. Higgins will be delighted to answer your questions. And we do have another question here, and it's, if you have seedling fibroid lining the wombs, should this warrant a hysterectomy?
So first and foremost, I think it's important. I'll answer the question, and then I'll editorialize a little bit if you give me those liberties. So fibroids can be little seedlings. Fibroids can be little or small melons, right, in terms of sizes. Okay, so we'll just start off by sizes. Fibroids also can occur in different locations in the uterus. Okay, so if you think about the uterus like a hot air balloon, for example, it's kind of shaped like a hot air balloon. And then if you were to take little arms and stick those on the side of the hot air balloon, you have the tube that sort of feeds to the ovaries, right? The fallopian tube, the oviduct, right? On one side, and then on the other side. And then on the inside of the hot air balloon, there's sort of layers, okay? The most inner layer is the layer that sort of thickens over the course of the month and then sloughs off in the form of a period, okay? The endometrium, right? So that thickens, as we talked about, sort of the estrogen sort of having sort of a well choreographed sort of highs and lows over the course of the month. That in part, along with another, maestro, which is progesterone, which is another hormone, that sort of kind of balances that sort of thickening, and that's loss up. Then just sort of deep to that layer is another layer, sort of a muscular layer, and then deep to that muscular layer is the skin of that sort of hot air balloon, right? And then you have the pelvis outside. Okay, so fibroids can occur anywhere between that skin, okay? Just below it, subserosa, the skin is kind of called serosa, so just below that is subserosa, so that's where they occur. And then they could be in that muscular wall, myometrial, sort of the mural, intramural, between the walls. They could be just sort of superficial to that, just sort of deep to that layer that sort of sloughs off, submucosal fibroids, or they can hang from a stalk into the endometrial cavity, in which they're called intracavitary, or they can extend outside the serosa on a stalk, in which they're called pedunculated. Okay, so they can occur anywhere. So in the case of sort of the ones that she specifically referred to, which is the ones that are sort of lining the womb, she's lining the womb, they may be sort of submucosal underneath that area that sloughs off, or intramural, which would be the more common ones, or subserosal. If you have those, they can be treated via a hysterectomy, of which you're taking an entire uterus. If that's what you're into and you want to do that, and that's a conversation you have with your doctor, and you understand the pros and the cons of taking out uterus, you understand the 6 to 8 weeks involved, you understand the scarring, you understand whether you have keloid skin or non-keloid skin, you understand that you obviously are not going to get pregnant because you won't have a womb. If you understand that now that's not the only option, then that's, obviously what you want to do, and, teach their own. Then obviously, that there's a second option, which is obviously the myomectomy, where you're surgically removing, obviously, the fibroids, and that can be done by an open surgery, of which that open surgery will be a transverse or longitudinal incision, of which that can also be a 6 to 8 week recovery. of which obviously keloid, non-keloid skin, same thing. You're thinking about that. Obviously, the fact that you're removing these ones that are maybe causing you symptoms related to bleeding or bulk symptoms, and you make an educated decision on that, then that's again your decision. But you also want to be aware of that. Of course, there's another option, which is sort of what I offer, which is the embolization technique, where we treat the little seedlings and we treat the melons all the same. And in the Bahamas, I've had women. I just had one woman on Friday, and I'm usually in there an hour and a half, and we were in there three hours just because hers were so big. But she came on Friday and she was showing off her tummy. It's just been a month, and she was doing a little looking at me and like doing a little dance, just so happy. And I said, I sort of looked at her like, she kind of, before we got started, she's like, "Are you sure you think you can handle these?" And I said, "Come on now, come on now." And we've dealt with ginormous fibroids, right? And we have women who, and their husbands, there's one particular woman I'm thinking about where her husband came in, first time I met her, both of her husband and her were just sort of kind of, just a little lower morale, of course, dealing with this issue. It's not just her issue, it's also his issue too. And then now, I remember the follow-up visit when they came, and she was like a new woman, and her fibroids were huge with 3 U's, okay? And him, he was just looking at me so proudly as she was telling her story, and he's like, "This is the wife I really wanted to introduce you to the first time, but she wasn't present because of these damn fibroids, essentially." So it was nice to see him sort of recognizing that she got her life back, even though these were like watermelon-sized fibroids. So.
Right. I love that. Let's talk about that. And this is a little further down, but because you're talking about size now,
sure.
What is the biggest size fibroid that you've treated or you've seen?
I've treated fibroids that are up to, so if you were to feel, so your sternum, okay, so your sternum, so this is obviously your chest bone, and you keep going down your sternum, and you say right below here is just below your sternum. It's the xiphoid process. So I have felt fibroids to this level. Right. And that's your abdomen, actually. So your pelvis, your pelvis is where if you put your hand on your waist on your kimbo, that's your pelvic bone. Okay. Right. So fibroids are usually in that bowl. Right. So that's one cavity, which is your pelvis. The other cavity is your abdomen. Right. So fibroids were basically all the way up, like these 3 women in particular who had this, and this is one of them. I tell them they're hiding a penguin inside them. This is how, it was just like a penguin just sitting in the pelvis, but obviously the top of the penguin all the way up to just below, that xiphoid process. No, it's not. So it's not one fibroid. And so I really want to, when I'm talking to women, I try to get them to not talk about numbers of fibroids, right? Okay, because what we're treating is a conglomerate. It's like if I was to sort of make a snowman or snow woman, okay, non-gender, snowman or snow woman, right? And so they're there, and they say, "Well, how much snow did you have to remove? When you tore down the snowman or snow woman?" No, you look outside, there's no more snowman or snow woman. I can't really talk about it. It's gone. It's gone. This, I was in collecting snow. So it just depends on your mechanism for removing the snow. If you are somebody and you're taking Christmas lights, off of trees down Bay Street, and you were to say, I need to get all these lights, off, man. This is too much light down Bay Street, right? We're done with Junkanoo, done with New Year's. If I was to climb up in the trees and that was my way to remove and get the lights turned off, that would be one way, okay? But if I say, it's plugged in John Bull, this one plugged in the Colombian Emeralds, and I pull out the lights and there's no more lights, you're like, "Oh my goodness, thank you. There's no more lights. It's perfect. You can leave the lights in the trees now," right? So you think about that, and these are 2 different mechanisms. So when we think about sort of fibroid, what we're doing is we're turning the lights out, right? We're killing the fibroids, okay? So we're not thinking about how many lights, it's thousands of lights, because there's usually scores and scores and scores of fibroids that even imaging can't see, right? You have some surgeons, one surgeon showed me a picture, and he had about 18 fibroids lined up, right? And certainly that's the ones that he saw, but there are ones that sometimes you don't see, right? Because, and it's not because you just can't get to them. You just can't see them to even say, oh, target them.
Right.
And that's just the nature of sometimes the way things are sort of positioned within the pelvis.
Mhm.
You know, if I say to you, you know, how many ticks are on your dog, and you say, all right, yeah, man, I could get all the ticks off my dog. I'm pretty good at that. And you go and you spend an hour removing the ticks, and I go and I remove the air. I move the air, and I say, oh, well, what about this one? You say, oh, I didn't see that one,
Yeah, you
right?
missed that.
And then you start feeling bad about yourself. No, don't feel bad. You just didn't. That's just you just wasn't. You spent an hour on the dog. You removed most of the ticks. You thought you were done, and there just happened to be one behind the ears, right? So this is sort of how things are. So we don't sort of comfort. What we're doing is we are basically cutting the blood supply to all of them, which we'll sort of kind of get into. And so when you think about sort of the penguin, as it were, you know, you think about a silhouette, you know, behind a shadow. That's basically, we're looking at that conglomerate of the fibroids, and it's usually multiple within them that make that penguin shaped sort of kind of fibroid conglomerate.
All right, so I want to transition. Let's go back to the initial questions,
Please,
and one of them would have been, what are some of the symptoms of having fibroids for women?
So that's good. That's important. So when you think about a woman who has fibroids, you have some women which they don't even know they have fibroids.
Yeah.
So they're asymptomatic. They're walking around happy-go-lucky. They may have a little small one. So that's the first thing is there's no symptoms. There are two major categories that a woman can present symptoms in. The first category is what we call bleeding symptoms. Okay. The bleeding symptoms are essentially heavy menstrual periods. Okay. In the heavy menstrual periods, you know, many women have sort of 5 to 6 day periods. And within those 5 to 6 day periods, you know, maybe at one point in their life, they had, you know, 1 pad or 2 pads, or up to 3 pads, maybe that were normal in terms of their flow. And then they started getting 4 or 5 or 6 pad changes, and they began seeing clots and things of that nature. So heavy periods, okay? And because of that, because they're losing more blood than they are making in their sort of bone marrow, they end up obviously having what we call anemia.
Yeah.
And that anemia may be asymptomatic anemia or symptomatic anemia. Asymptomatic anemia means, okay, your blood counts are low, so less than 11, you know, sort of the number, the threshold. The symptomatic would be sort of a number of things. You start walking to the parking lot, you know, you walk away from your friends, maybe Odessa's there, you walk in the parking lot, and Odessa's just chilling, and, you know, you're there, and you're just like taking a deep breath in, right? And you take a deep breath in, right? You say, well, why are you taking a deep breath in? What's going on over here? Yeah, man, you look nice and fit over here, man. You know, why are you breathing in? So the reason you're breathing in is because you have less circulating blood volume because you've lost it in the form of your period, and your lungs are saying, oh, we need to oxygenate more of that limited blood supply so that it can oxygenate the tissues. So you start taking in more oxygen. The second thing that happens is, boy, you start putting your hand on your chest. So, well, man, Odessa said, why are you putting your hand on your chest? Putting your hand on your chest because my heart beating a little fast. Well, your heart beating fast. Your heart is beating fast because your heart's saying, I need to pump more blood per second because I got less blood soldiers to feed the tissues to deliver oxygen. So your heart says, man, I got to work twice as hard because I got about half the blood volume I normally would have. So I pump it faster. So you see, and what ends up happening over time is with that symptomatic anemia is your heart, you can also get what we call a high flow heart failure because your heart's working so quickly over time. It's overactive. So that is sort of an issue that can occur over time. The other thing is, you know, people can get lightheaded, right? So what ends up happening is if you think about your engine check light, right? Engine check light comes on. What's the first thing that comes on if you start having an issue? You get a little headache, get a little lightheaded, right? You know, some women that have passed out that have talked to me about they passed out, you know, just because they're doing something and they just go black and they pass out. And so that's when you know they're really symptomatic. And so that's sort of the peak of sort of symptomatic anemia. So that's the bleeding symptoms. Now we shift into the room of bulk symptoms. Bulk symptoms is basically has to do with the fibroids exerting mass effect on areas that really don't need to have mass effect exerted on them. So as I started by saying, which was a great question, Coach Trish, which is that, what are they? So I said they're muscular tumors. So if you were to flex your muscle, you say, man, Odessa, flex your muscle for me, right? So you grab Odessa's muscle, you feel Odessa's muscle. You said, boy, this hard, right? So, and then Odessa, like, I can't keep this up no more. She relaxed, right? So imagine if Odessa was flexing all day, 24/7, 365, right? That's what the fibroids doing. The fibroids doing just, you know, just Mr. Mrs. Olympia all day long, just flexing.
Yeah.
And so what happens is everything in the pelvis that's soft is impacted by this bully, all right? So what's the first thing that's impacted? So if you say, all right, I got to use the bathroom, right? You're like, well, the reason you use it often because your urinary bladder is filling up with
Yes.
urine, right? So if the urinary bladder fills up to maximal capacity, maybe maximum capacity is about 12 glasses of water before you say you got to go. But then it can't get to 12 because it got this bully, this muscular sort of tumor in the way that's pressing it. So now it's just like, boy, I can't get to 12 glasses. I got to get to 10. Or maybe you got to get to 6, or maybe get to 4 before you feel like you got to go. So those women have increased frequency, increased urgency. The other thing is if you think about sort of the bladder is right in front of the uterus, right? And so behind the uterus is your rectum, right? So your rectum is the terminal portion of the colon, which is the terminal portion of your gastrointestinal tract. So if you have stool coming down, coming down, and then you got a bottleneck, right? And the stool's like, wow, you got this bottleneck. I need to leave, right? And you say, boy, you know, the reason I gotta leave is because I gotta go. So, but then the fibroid's pressing on the rectum, which is a soft structure, and you're backing up, right? And so I have some women who come to me and they say, boy, doc, man, you know, I said, how many bowel movements? I said, man, I really ain't gonna tell you that. I said, well, why you don't tell me that? Man, I just one bowel movement a week. And I said, what? I said, well, you know, I've had 2 women say to me one bowel movement a month, right?
Wow.
So, you know, unfortunately, you know, one of the saddest things about my work is that I found that people can get used to very uncomfortable and severe conditions to the point where they consider it normal. Okay.
Yes.
And so constipation is another symptom. A third symptom is bloating. So when you think about the fibers that are studying the uterus, right? So you think about, say we are supposed to, you know, walk on this carpet, and I used to throw a couple marbles under this carpet, and I say, yeah, man, walk on this, and you say, man, this don't feel good. I said, well, you know, okay, they don't feel good. Well, why you don't think they don't feel good? Well, because the marbles are underneath the carpet. So you think about, well, you say, man, why your tummy don't feel good? I don't know why my tummy don't feel good. I said, well, why you don't feel good? I feel bloated. Well, you know, reason you feel bloated is because you have these marbles underneath your carpet. You have these fibroids studded underneath your abdominal wall, and that's making you feel uncomfortable, right? Same way that if you were to walk on a carpet with marbles, you feel uncomfortable, and you're dealing with that every day, and it's hard to verbalize that. So that's bloating. A fourth symptom would be pain on intercourse. So again, you know, if you were to go to West Africa, one of these wonderful women would probably walk past you with a basket of fruits on her head. And you say, wow, this is a heavy basket. How is she able to carry this basket? And if some soul was to say, man, let me see if I could provoke this woman. So they go and they start shaking the woman. And the first thing she's going to hold is her neck, right? Because she said, well, now she feels it heavy. So imagine you carrying all these fibers around. You may not feel pain until you have intercourse. But when you have intercourse, it will be excruciating pain in many cases. And so some women have such excruciating pain to the degree where their relations with their partners are constrained. Okay. And so again, when I see a partner come into the room, like on Friday, I had a partner come into the room, I know he is invested.
Yes.
Okay. You know, for reasons
Thanks,
that
Doc,
when I look at him and I look in his eyes, he say, Doc, you know my pain, bro. You know my pain. So he looks at me and I say, and when I start, you know, talking about the symptoms, he looking at me and say, that symptom right there, that's a symptom while I'm here. You know what I mean? Kind of thing. Right. So
fix that one now.
That one right there.
Yeah.
So these are all the symptoms that sort of a woman can experience, you know. So, you know, constipation, increased urinary frequency and urgency, pain on intercourse, bloating, and then those are the bulk symptoms that we typically deal with. So to recap, the bleeding symptoms and of course the bulk symptoms.
Doc, your girl had all of them.
Yeah, I recall.
And I am so excited, and I can't wait to share my story. But let's move on. Let's ask some of the questions I see here. I have a family member, someone is saying, that has had fibroids for at least 30 years. I understand that she has had them removed before, but for 25 years she looks pregnant. Her stomach is huge. Is it true that after a while there is nothing that can be done?
I would say negative. No, completely. If you say 30 years, I would want to know how old the person is. If she is premenopausal and she's still having periods, then I would say absolutely there's something can be done. So the answer to that question would be.
Here's another question from Facebook. When the size is huge, do you recommend surgery or the procedure you perform?
Yeah. So for me, again, you know, I think everything has a place in the kingdom. Okay. And so, you know, when a person sees me, they're seeing me so that I can assess them and determine sort of what it is that I would recommend. There are women that I've recommended based on sort of the situation, okay, this is where you're at. I think a hysterectomy would make sense,
Right.
If you're having a consideration and you're like, okay, you know what, a myomectomy. So I referred to one of my colleagues for myomectomy.
Let me cut you.
Please.
Since you're on that,
Yeah.
let's talk about the various procedures that
Sure,
can be done.
sure,
The
sure,
surgery,
sure.
anything that can be done to eliminate fibroids, since you're there. So
Yeah,
I
yeah.
guess whoever's listening can decide which one may be
100%, 100%. Yeah.
Mhm.
So just to sort of kind of go back to this a little bit. So the first sort of procedure is you have fibroids,
Yeah.
bulk symptoms, bleeding symptoms. You say, all right, let's remove the entire uterus. Okay.
Right.
So you basically perform a hysterectomy, and that could be open. Many cases in the Bahamas, it's an open. They make an incision, and they scoop out the uterus and they remove it with or without the ovaries. Okay, with or without the ovaries. Okay, which both have sort of considerations whether you remove the ovaries or not. So when you do that, the first thing that you should celebrate is that you never ever ever have to think about fibroids ever again. Reason being is because that genetic predisposition is null and void because you don't have a uterus anymore.
Right.
Okay. So if you want to celebrate that, then that is something certainly to celebrate, that you have no more fibroids. That issue not only is non-existent, but it'll never recur. So if you were a 45-year-old and you're done with pregnancy, you say, man, you know what? I can't even, you say fibroids go on an 8 to 15 year cycle. So 45 plus 8, that put me at 53. Average of menopause is 51, but man, my mommy was still having periods up until she's 57. I don't want to take that chance. I don't even want to see nobody no more. I'm going to remove my uterus.
Right.
So I said, what? That's how you feel? Okay, my dear. I think that was great. These would be, some folks that I'd recommend, that we collaborate with. These would be some gynecologists, and I would recommend they would go to see them. 6 to 8 week recovery. Obviously, there's an incision involved.
There's a hysterectomy.
Hysterectomy. Some women, when they look at that timeline, they say, okay, 6 to 8 weeks. Okay, I'll take some time off from work and go ahead and do that. And then you move on to the next category, which is, okay, a woman who says, you know what, I really don't want to remove my uterus. What other surgeries are available to me? So the first surgery that would be available to a woman would be an open myomectomy, which is sort of what by and large would be the second sort of alternative here in the Bahamas. And that would be a surgery where same type of incision, so transverse or longitudinal incision in the abdomen. And instead of removing the entire uterus with or without the ovaries as an option one, they would essentially be scooping out the fibroids that they see. They say, oh, there's a fibroid there pressing on the bladder. That's probably why she's having the urinary frequency inerrancy. All right, let's scoop those 2 out. Boom. Oh, there's 3 that are sort of pressing on the rectum. That's why she's having one bowel movement a week. Let's remove those 3. And then they move as many as they can. Seedlings, little, Roma tomatoes, little beefsteak tomatoes, little cherry tomatoes. They remove them and they say, all right, we good. And they sort of push them up, and then they have 6 to 8 week recovery again. And the beautiful thing is the following day, those bulk symptoms would be gone. So constipation would be obviously removed because the culprits would have been removed. The increased urinary frequency would be removed, would be extinguished because obviously those fibroids that are pressing on the bladder would be extinguished. So in the case of the bloating, less likely to feel that because those ones studying underneath the anterior abdominal wall would obviously be removed. When it comes obviously to women who still think about it, they say, well, I don't really know if I want an open surgery. Right. I don't really want to undergo the knife. That 6 day recovery don't really sound good. So they say, man, doc, you have another surgery like that? They say, well, the other surgery would be a laparoscopic. So now you move to option 3. Laparoscopic would be whereby they say, all right, what we're going to do is we're going to make 3 incisions. Okay, 2 centimeter incision here, 2 centimeter incision here, 2 centimeter incision here, and I'm going to put my cutting tools through 2 of those incisions, and I'm going to put my scope with a light through the 3rd incision, and I'm going to sort of move around the abdomen and try to essentially evaluate whether or not I can essentially get all of these, fibroids. And so surgeons that are particularly skilled can do a very good job and get a lot of the fibroids. And obviously, depending how big the fibroids are, they may or may not be able to remove those through those 2 centimeter incisions. They may have to extend the incision in order to make it a little bigger in order to pull them out of the body. So it just depends on the size of the fibroids, what they're able to do laparoscopically. And so some surgeons may say, you know what, mom, I want to do a really good job. I need to do this, big surgery on you. I need to, kind of make this big incision because I don't want, if I do a laparoscopic surgery where I miss things, you know what I mean? Kind of thing. I want to really set myself up for success. And so the laparoscopic may be something that they may not offer, you know, and they may discourage, you know. And then the fourth option, which we'll sort of kind of stop at today, would be the one that I offer, which is uterine artery embolization. And that is basically where I go into the groin, right? So if you feel a little pulse in the groin, I identify that artery that's sort of pulsing. I put a little needle in there, and through that needle, I put a wire. I take my needle out, and over that wire, I railroad a catheter. And then using live x-ray, I see my catheter moving, and then I identify the blood supply to the fibroids on the left side. And what fibroids do is, in hijacking the blood supply from the uterus, they create a spider web, right? Like collateral. So if you were to say, man, where the spider web, this cobweb come from in my house? Man, a spider web create that, you know, a spider created that, you know, for itself, you know, so it could do what it's got to do and collect what it needs to collect to eat. And you said, but I didn't even know that. You left the spider. You don't have to let him in. He just came in and he just set up shop, right? That's what the fibroids are doing. They setting up shop. They living high off the hog, and that's what they're doing, right? They don't care about you. They just living, okay? So what we do is we block off the blood supply, and the way we do that
is that how they feed?
They feed by the blood supply of the uterus, right? And so what they're doing is, you know, I use the analogy of you taking ticks off a dog, partly because I think it's a great analogy to visualize how difficult it is to remove them. Right. But also, I think it's helpful to think of them like ticks, right? Well, what are ticks doing? Their nature is to suck blood. They don't care about the dog. They don't care whether the dog ain't feel like going for a walk no more. They don't care whether the dog ain't want to drink or eat. They just want to suck blood. That's their nature, okay? So what the fibroids do is their nature is to suck blood from the uterus, right? And so what I then do is in that network, I basically dismantle that network by basically putting little tiny particles into that network that blocks off the blood supply that then kills the fibroid, okay? So it's like rat poison for the rat, okay? So once that is ingested, basically that rat dies in the same way that once I block the blood supply to the fibroids, they need oxygen. Like any living thing in the body needs oxygen. So once it is devoid of oxygen, it dies. Okay. And then I go on the right side, do the exact same thing to the fibroid on the right side. I identify the collaterals to the right side of the fibroid, and then identify if there's any other collaterals, and then block up them, and then they die. And as I would have, you know, kind of would note in a conversation with a patient, is that, you know, when you think about 100 women coming with bleeding symptoms, those 100 women that are coming with bleeding symptoms, if they were to get this procedure, you know, they're coming in with sort of 5, 6, 10 pad changes during the course of their 24-hour every day, the course of their period. 97 out of every 100 by the following period, like those 5 women that I saw on Friday, high-fiving and giving me hugs at the end of their visit, they would be symptom-free, you know, to the point where they're just like one of the women on Friday said, man, I changed my pad 5 times just out of curiosity. You know what I mean? Because I couldn't believe it. She said, you know, panty liner, I don't even know what panty liner is no more. Say, but that's what I'm wearing now, right? So to that point, they would be 97 of every 100. Now, if they're coming in with bulk symptoms, so constipation, pain on intercourse, increased urinary frequency, bloating.
It takes a little longer.
It takes a little bit longer. So for every 3 women that get the procedure, 2 out of every 3 women after 6 months would have a 50% reduction in size of their fibroids, okay? And so if the fibroids started at 10 centimeters, they would go to 5 centimeters at essentially 6 months in 2 out of every 3 women. But the beautiful thing about the 97% is that once the fibroids are dead, and this, you know, one of the women I'm going to be on another show this week, and I mean, she for me was the first person where I've said, you know, once I saw the way her body changed within a month, you know, it's so much easier to you know, essentially move the fibroids around because they're dead. It's like you start off with a coconut that's hard, and then you move to Play-Doh. So you could essentially mold, you could push your hand in before and they would push you back, right? You know, you say, man, don't push me. Whereas, you know, afterwards now you push in and they just give with you. They just so submissive.
Right.
So some women now, they teach me, they say, man, doc, you know what I do now? Man, I used to wear them waist trainers. Before I used to wear them, and they never used to do nothing for me. Now when I wear them, man, I might as well call this a BBL because I feel so good, right? You know. So they say, man, you gotta start advertising. Like I said, no, I can't advertise like a BBL. I said, no. Look at my waist. I said, okay, all right, yeah, you're right.
So here's
a
question about your procedure.
Yep.
Someone asked in this uterine fibroid group that I'm a part of.
Yes.
It says, I have a couple questions regarding the beads used for the UFE procedure. Do they get absorbed after time? Can they travel to other areas of your body and cause issues? For example, could the beads travel to your eyes and cause vision issues?
Okay, so the first question, just to answer that, is no. So, and my colleagues always say, you love your analogies, and I say, analogies, I think, the good Lord spoke in parables for a reason, to convey the good word, and I take note. So, to answer the latter part and then move to the former part. So, if you were to drop the particles, would they go to the eyes? Okay. So first question is, are I were to throw a rock in Chippenham, is it going to hit somebody in Pinewood? Probably not, right? Why? It's because of gravity, right? Gravity can say, no, this rock got to go on the ground, and it ain't going to Pinewood no more. You're in Chippenham. If you are in Baintown and you throw a rock, is it going to hit somebody in Life-Key? No. It ain't going to hit somebody in Life-Key. You say, well, why? Because gravity is going to say, no, you can't throw it that hard, okay? So when you think about sort of the blood supply to the body, there are networks, right? So, it's like, to use another analogy, if I turn right off Thompson Boulevard, is there any chance I could end up in Old Fort Bay? Probably not. No. Probably not, right? So the blood supply is a network where people in my field, we know the network, we're like taxi drivers. We know if we turn right by the kidneys, where we can go. We turn left by the gastrointestinal tract, we know where we can go. If we are in the pelvis, we turn right, we know where we can go. If we in Chippenham, if we turn left, we know we ain't gonna end up in South Beach, right? So that's just how it goes. So if you think about sort of, dropping blood flow, and blood flow is flowing in one direction. If you're flowing in one direction and I drop, this particle in and it's going down, towards Chippenham, it's going to continue going down Chippenham until it stops. And that stop point is the very tips of the blood vessels. That's the very end of it. So when you lodge these particles in, they're going to the very tips of the blood vessel in that territory, and then that's it. Okay. So when I'm feeding in the fibroid, in the blood supply to the fibroid. So I'm working my way to the blood supply to the fibroid. And now then I say, all right, the faucet's turned on. I'm imagine my sand particles in to the sink, and I'm, with the faucets on. And this is the faucet for the fibroids, not the faucet for the eyes, not the faucet for the ears, not the faucet for the lips. It's the faucet for the fibroids. So I'm giving, if you think about the rat and the rat poison, I'm just giving the pellets to the rat, not to the birds. Okay, not to the flamingos, just to the rat, right? So that's where it is. So that where the tippy tips end in the blood vessels is where they stay. Okay. So to answer the question in terms of the beads, once the fibroid's dead, they're dead. They get absorbed. Okay. And so the beads are part of the sort of absorbed fibroid.
Right. Yeah. Okay, here's another question. Is it impossible for subserosal fibroids to be removed by UFE? I have seen one radiologist who thought it was too risky, and this question was also from the UFE group that I'm in.
Yeah, so it's always hard for me, and unless I have a consultation with a woman, to understand what somebody would have said and why they would have said it. But I also try, without sort of getting the information specific to the case, to sort of say, okay, yay versus nay in a particular specific case. But to answer that general question, no. I mean, we treat subserosal fibroids all the time. There's really no risk to a subserosal fibroid. It's underneath the skin of the fibroid. It's like, if within the walls of this building, right? If there was a dead dog, if there was a dog, or there was some parasite, or something that was that took rat poison, it would essentially stay in that wall, right? So that is a safe treatment because it's in the wall. There's no issues. It's all contained. And that's typically what we do. We usually treat within sort of the wall of the fibroid. And so the serosa is the skin, and everything deep to that is what we would treat. Okay. Some people would say, in the case of, say, fibroids that are deep to the endometrium, which is the part that sort of grows and sort of sloughs up the form of the fibrin. If there are little fibroids sort of underneath them and they sort of die, some of the women can sort of pass those fibroids, and that's sort of normal. That could be sort of in the form of sort of a watery sort of expulsion, is what we call it, or it could be bulk expulsion, where you have almost little pieces of chicken breast that sort of pass, meat like that passes. One of the 5 women on Friday, actually I had women that had all 3 types of expulsion. One had the watery expulsion that lasted for a few days. Another one had sort of pieces of meat that had passed. But in addition, and these are just pieces that were part of the conglomerate, right? There were probably 97% that was in the wall, but these are just pieces that sort of kind of chipped away and sort of kind of fell out. So there's no risk per se. It's just, what you anticipate and what you plan for and what you expect, so that you can sort of make people aware as they move forward in their healing process.
Okay. And now this question is from the Facebook group. Live. I had a myomectomy 9 years ago, and they returned and just had UFE last week. I'm looking forward to post-procedure results and gaining life back at 44 years. Question. I had the procedure 3 weeks ago, and that's the same person? No, that's not the same person. So that's just someone actually just making their statement. But there's a question here that says, I just had my procedure 3 weeks ago, and my period was due last Monday. It didn't come. Is that normal?
Yeah. So don't know whether the person had it done, but it's always good to know. So when a person gets a fibroid embolization, the specific one that you're talking about, correct? This is somebody who got a fibroid embolization 3 weeks ago? Yeah.
Yes.
So when you get a fibroid embolization, so the first thing is that you are essentially, again, blocking off the blood supply to the fibroids. So what ends up happening is your body is sort of kind of resetting in that region, okay? So it all depends on when the period is going to occur or when it was expected in relation to the treatment. So for example, I'll give you an example. So I have one woman, I'll give you two women examples from Friday. Okay, so one woman had her period, expected a period within 2 weeks post procedure. So what I told her is, you are probably gonna have a normal period, because it's almost like that period is like if the water, say water and sewage cut off the water, right? And man, you turn on the faucet, you say, man, I still got water, and you wait 30 seconds and then the water cut off, right? So if you continue after 30 seconds, you turn it off, you may never know that the water's off because there's some water still in the pipes, right? So that's sort of a little analogy. So she had a normal period. But now, fast forward, you have a woman who essentially was expecting it, she had just had a period before, and she ended up with the procedure. Now she sort of have, 3 weeks, at least before her next period. Now she could appreciate the fact that obviously her period is now normal, right? New normal, essentially, because the body has had some time to reset. I'll give you a third patient from before. What I tell women is that within the first 2 to 3 months, they could either have no period, they could have a previously normal period as sort of first one, or they could have their new normal period, okay? Or they could have a fourth thing where they have essentially no period ever again. Okay. And the women that typically would have a higher chance of having no period ever again would be women that are over the age of 45, right? Okay. So what they say is that if you're less than 45, you can have a 3 to 8% chance of never having a period ever again. Okay. If you are over 45, you can have essentially about a 33 to 50% chance of never having a period again. And the closer you are to the average age of menopause being 51, you can obviously be closer from that 33 to that 50%, right? And I have one woman who I treated last August. That's how I treated her. And when I quoted those numbers, she said, "Please, Lord, please let me be in one of those 50%, that 50% group," because she didn't want to see a period ever again. Wow. And I had one woman in November who I treated, and she had 2 months of no period. And then the third month, the period came back, but she used to have like 9 pads a day she used to change. And she came to see me and said on the third month, she had 2 pad changes. So she went from 9 to 2, which remember now, the first 2 months she had no period. So she comes to see me 5 months now, and she said, "Doc," I said, why you look so sad? She said, "My doc, those first 2 months were so sweet, so sweet." She said, "Man, I is this really supposed to happen? Why I supposed to be? I thought you said 50% was a chance to never come back again." So it just depends on where you are and what is your experience. So to answer that person's question, yes, it is in this first month, it is normal to.
Which is awesome for her because she says she's 34 and she still wants kids. And she told the doctor the only reason why she had the procedure, which is the UFE procedure, is to shrink her fibroids so that she could have the kids. She said she had 9 centimeters and a 6 centimeter fibroid.
There you go.
Yeah. Yeah. So, you're welcome. You're welcome. All right, so let's talk about the actual steps when coming to you, right?
Mhm.
We come to you for consultation. Of
Mhm.
course, I know, but for
Sure,
persons
of course,
who
of
want to
course.
know how
That's
to
what we're
do
here
this.
for. Yeah.
So the gynecologist would say, okay, let me refer you to the interventional radiologist, Dr. Mikhail Higgins, right? So this person comes in your office. What happens from there? Let's talk about all the questions that you ask, etc., before we get to the actual procedure.
Sure. Yeah. So women, when a woman sees me, the whole presumption is that she has some degree of care, right? And that could be a gynecologist or that could be a primary care doctor.
Right.
A woman self-refer, which is fine. When a woman self-refers, I work at a family medicine center, and so when a woman comes, they see one of our sort of kind of primary care doctors if they don't have one, and then they sort of kind of get things squared away then. So usually the first question is, how do you know that you have fibroids, right? And so we have to start with sort of how that diagnosis was made. Is it sort of based on your suspicion? And if it's based on your suspicion, then we need to validate that suspicion. So before a woman sees me, usually they would see somebody at family medicine center, and at family medicine center, that person, that primary care doctor, would sort of, if they sort of get a history that sounds like, okay, this could be fibroids, they would get an ultrasound. And that ultrasound would then show that, oh, there's fibroids present. Oh, there's fibroids by itself, or there's fibroids with something else that's causing these symptoms, like adenomyosis, which is another condition that often sort of confounds the presence of fibroids. And these are sort of what we call ectopic endometrial glands within the uterus, and they have similar symptoms. They have painful periods, but they also have heavy periods as well. So you can have, essentially lice and fleas all causing sort of kind of very similar symptoms, but two different entities. And so they would sort of do that. And so now I know, okay, boom. And then they would sort of say, hey, we have this patient, we'll then refer that patient to you. Or they may say, oh, this patient has other things that we need to manage, the diabetes and hypertension. And so now I know that those things are being cared for. And so those things are being managed appropriately. And so then the patient's referred to me. So it's always good to know, when a patient sort of self-refers, they get what they need before they come to see me, but making sure that the other issues, the comorbidities that they're dealing with, are also being tended to. What we want to, what family medicine center, we always sort of focus on is treating the patient as a whole, recognizing that there's really no benefit to being tunnel vision because everything affects everything, right? Which we'll sort of get into. We talked about the obesity, sort of obviously even linked to the fibroid growth and recurrence, but we'll sort of dive into that a little bit more, why the fitness, the nutrition is really part of my collaborators' sort of focus on fibroid care, which is what I'm leaning to and structuring my focus on. So when a person then comes in to see me now, self-referred or, again, passing through, referred by their clinician, when they sit down, they have their labs. The labs will then show me specifically to sort of zone in the fact that they have anemia or don't have anemia. So when I talk to them now, I'm talking to them with, oh, you have lightheadedness. Oh, okay. Your hemoglobin is 8. Okay, all right. It's not in the sort of 12, plus range. Okay, so it's not normal. Oh, you have palpitations when you walk up the stairs to see me. Oh, okay. Your hemoglobin is 10. Now it's symptomatic, right? So I'm seeing the labs and I'm mapping them now prospectively to what the patient's going to tell me. Okay, iron is also low. The ferritin is low, which is obviously one of those metals that sort of bind to the oxygen carrying capacity of the blood that sort of allows it to sort of do its job. Now, the other thing that I would then look at, I would look at the ultrasound. I would see the fibroids. I would look at their location. What we know is that fibroids that are sort of underneath that area that sloughs off the endometrium and the form appears every month, the more you have in that location, usually the sort of more likelihood that you'll have sort of clots and heavier periods. So that's sort of something that's sort of a little bit of a trend in sort of what people may experience. And so I get to know sort of where things are located. And also I know that if I was to treat this woman, there's a chance that this woman could pass some of these fibroids, because once they're treated and they die, they could pass out. And so I'm taking all these things. So again, we take all this information, and I know as I talk to the woman now, I know how I'm going to approach her. I know sort of, the severity of her symptoms in terms of the bleeding symptoms, and as it, because I'm matching them to the fact that she has anemia. If she has anemia, I know that if she starts talking about eating ice, That's one of the conditions that's called pica, which is sort of a really a pathognomonic, what we call something that's highly characteristic of somebody that is anemic, because they want to eat things like dirt or eat sort of chalk or eat things like ice. And so I know those are things that I could be listening to. So again, that initial workup by my colleagues at Family Medicine Center or others that'll pass that information on, that'll then allow me to then say, okay, boom, I know going into this what I'm going to be hearing, and then I could kind of walk through my checklist. And then I get the history from the patient, and then we educate the patient in a similar fashion that obviously the great question you've asked today. And then we then walk through the options, and then the patient then sort of kind of makes a decision on what they want to do, if in my mind, you know, they're a great candidate based on what it is they would have presented.
Okay. All right. So that's the consultation.
Yeah.
So what happens next?
Yeah.
Let's say let's go. We know we got to do all the insurance work and the paperwork.
Oh, sure.
Let's go to the procedure.
Yeah. Which again, I stay out of all the paperwork.
All the paperwork. That ain't for you.
I got some amazing people in my corner. They deal with all that, and so it allows me to spend more time with the patients. And you know, and as you would know, as you know, once a patient, once I treat a patient, you know, I'm in touch with them essentially, you know, making sure that I'm checking in with them and that sort of thing. And so for me, the next step, so I have two teams. So I have one team at Family Medicine Center, amazing folks. You know, two of my medical assistants, Siobhan and Tanisha, they're fantastic. I work with them directly, and they are sort of the gatekeepers for the women that I work with, and they are just phenomenal. So blessed to have them. So once they then, I approve them to sort of move forward with the procedure, and the patient makes that decision, we then move to the next step, which is to get an MRI. The MRI serves a few purposes, and the MRI is basically for me to see the location of the fibroids. The ultrasound is like, you know, if I was to stand behind a silhouette and you were to see me, man, you can't really see if I is a bodybuilder or not. I mean, you could see my little shape here and there, but it isn't until I come on the other side, you say, oh man, this boy got little muscles, man. You know what I mean? But so the ultrasound just gives a little general understanding of where things are. But the MRI really allows us to see what we need to see. Okay. And so I'm planning, I'm thinking, and it sees me the size, the amount, the quantity. And so as I map that out, then I have this sort of pre-treatment image, so that I know that now when the patient comes in 5-6 months later and I get the post-treatment image, and then the fibroids has had time to sort of, you know, basically shrink, I could show, oh, it was 10 centimeters now. Oh, it's 3, it's 4, it's 2 centimeters now, because it's now sort of absorbed so much over time. So I could show you that, and it can be, oh, this, you can actually see the difference between the two. So that's what the MRIs are there for, and then sort of mapping in my mind. Next step is, once the MRI is done, that's then sent to us, and then we pass you on to my other team. My other team is run by Nurse Rhonda Roll, also phenomenal human being and nurse, and just a quarterback for women once they sort of then are sort of moving into that realm. And what Nurse Roll does is she then tees the patient up to see my colleagues at Anesthesia Associates Medical Group, AAMG. So she works out of InterHealth, which are my partners, and so then sees the phenomenal folks in the anesthesia team. So we have, Dr. Barry McCartney, who's one of the anesthesiologists I work directly with. I had the pleasure now to work with Dr. Mark Weish, who is one of the anesthesiologists who was the people who sort of really inspired me, obviously, when I was sort of on my journey to go into medicine, with Dr. Reginald Neemore, who's also a fantastic anesthesiologist who I've worked with. And those sort of three predominantly are the sort of three doctors that sort of really sort of form the anesthesia group that sort of evaluates the patients. And what they're doing is they're looking at the high blood pressure, looking at the meds, looking at, okay, you have a little sleep apnea. Oh, okay, you have a little obesity. We need to think about that. Oh, you got your sugar issues. Okay. So when the patient now then comes to see us on the day of the procedure, which is at Doctor's Hospital, and Doctor's Hospital now, then they know exactly what the patient's going to get in terms of anesthesia. They know what they need to look for. And then when the patient shows up, my wonderful team at Doctor's Hospital then kicks into play. They get the patients ready. Once the patient is all ready, then they move them down to the cath lab on the ground floor. And I have my amazing nurse Clark and my technologist Jagan. They get the patient ready. And then before you know it, we're ready to start the procedure.
Quick question before we take our break.
Sure, of course.
I know I obviously did the procedure at Doctor's Hospital, but is there a reason why it's at Doctor's and not at the other hospital? Is there because of perhaps various tools or equipment that a hospital may not have that the other hospital has.
That's fantastic. Exactly. Yeah. So, in the other hospital being the Princess Margaret Hospital, correct?
Right.
Yeah. So basically, the cath lab at Doctors Hospital has been the only site that I've been able to do the procedures at, which has to do with the fact that the equipment is a very specialized piece of equipment that allows me to see what it is that I need to see, and in a way that allows me to essentially do my job. So it's not just a regular sort of piece of equipment where it's X-ray here or X-ray there. It's a very sort of precise equipment, the same type of equipment that you'd use to do catheterizations of the heart, which is a procedure that was an interventional radiologist sort of invented procedure. That same sort of equipment that allows them to do that work is the exact same piece of equipment that allows us to do what we do.
Okay, so let's take a break real quick because we get into the juicy part. So after he's already done, Dr. Higgins has done the procedure, we're going to talk about recovery and what happens there, the amount of time, so how long you get to see a period, and all these other questions that are pending. So let's take a break and we'll go from there.
Josh, Shoes and Accessories is your one-stop shop for all your footwear needs. Whatever the occasion, John's is confident you will find what you're looking for. Among our always growing collection of amazing and trendy styles, we cover women, men,
No, I wouldn't do that.
whole family.
Because we actually finished.
Yeah. Oh, okay.
Yeah, what we're talking about is just a recovery, and that's it. And then whatever questions that may come after, but we good, man. Thank you. We got Dr. Higgins, because most of the the recovery, he started turn it down a little bit, turn it down. The recovery, he was already talking a little bit more about that, so he'll just get into that, and then
like time flew by, man.
Very fast, and it was so
easy
informative.
crowd, man. Easy crowd, man.
The part about it is that he's very detailed and clear on his explanation.
Extremely.
So that helps.
Oh, thank you so much.
Yeah.
Oh, thank you.
Yeah.
Oh, thank you.
Because those medical terms, I'm like, what?
Yeah. No. They only good for medical people, man. They only good for medical people.
Your lane with Coach Trish Hanna.
Welcome back. For those who may have any further questions, you may not be on Facebook, but you're listening via radio or cable. We're giving you an opportunity to call 328-8164. That's 328-8164. And for those who have asked questions in the Facebook group, we have not forgotten you. I just want to make sure we get those pertinent questions. And just want, the whole purpose of the show is causes, symptoms, and treatments. We did the causes, we did the symptoms, we spoke about the treatment. Now we're talking specifically about the UFE, and we want to know with the embolization what happens after the procedure. So of course, everyone have their various methods and ways that they recover. So I'm going to ask Dr. Higgins to talk about a few that you've heard, what happens with their recovery, with all person's experience.
Yeah, no, so it's good. I think, it's so interesting when you're comparing the kind of surgery versus uterine artery embolization. I think a good way to think about it is almost like liposuction versus CrossFit, right? So if you go to liposuction, they sucking out that stuff, and you suck it out, here today, gone tomorrow. But when you go to CrossFit, the question is, what happens to the fat, right? What happens to the fat? Where does the fat go? Is the fat gonna go to your brain or your eyes or your ears? No, man, the fat, they burn it and it's gone. It's living fat that's now dead fat that's now being absorbed. So similarly, once you have a dead fibroid, it absorbs, right? So the question is, man, well, this person used to be so muscular back in the day and ain't got the muscles no more. Where the muscles gone? Did the muscles go to the eyes or the ears or the nose? Did it embolize to the feet? No. It just absorbed, right? So similarly, these muscular tumors, they die. We trigger the death, and they get absorbed. And so what ends up happening is, the first thing is the women see, which is what I wait for in text messages, is, man, my period, this should I be expecting no period? Because this is amazing, right? And then I see them in clinic in a month, and then I say, well, how do you feel now? They say, man, this is like an alternate reality, because panty liner, I was wearing, overnight, this is crazy. So that's what we see, what we expect to see, or someone saying, I don't have any period, man. I just had like spotting for 3 days and, X, Y, and Z. Or you have some women, where they're basically saying, yeah, so I had a bona fide low, light period, but then I'm obviously having this sort of watery expulsion for a bit, or I'm having some of the bulk expansion, some of the tissues passing. And again, I can sort of anticipate that based on the location and talk them through that. And then again, by the subsequent visit, non-existent, and we're high-fiving, we're looking at the MRI, and we're showing the fact that, okay, this is what they were pre and this is what they are post. And though that ends up being sort of the arc, and the more important arc is the fact that these women, because of the fact that there's no more tick, there's no more parasite sort of sucking their blood, living high off the hog, they now have the energy to live life and actually sort of really re-engage the wellness, which for me is where I'm at, because, as I would have said, like, this is me treating, but there's another piece, which is the nutrition piece, which is the fitness piece. And so, my collaborators, are sort of in those realms, because, obesity is something that, essentially enables fibroids, right? And also not only enables fibroids, but it provokes their recurrence. And so if a woman sort of obviously is obese, that estrogen that's in her sort of fat will still feed and provide fertilizer to, if she had, a myomectomy and there's little seedlings that maybe the doc didn't get, those ones will probably grow because the estrogen is obviously present. Similarly, if a patient had a UAE, like I've treated maybe 3 patients in the past, 2 years who've had UAEs between 2006 and 2010. And again, now over the past year, I've treated those. So it's perfect 8 to 15-year timeline, perfect time they're growing back. So perhaps if they were on sort of, foods that were promoting an alkaline environment, anti-inflammatory environment, then that tumor growth, which is exactly what a fibroid is, would have been extended maybe to 20 years or 30 years, and they never would have this current. So the people that I'm sort of partnering with now are in nutrition, that are sort of kind of focused on essentially the sort of, anti-inflammatory, pro-alkaline environment, so that we can sort of get women into this sort of internal sort of milieu where fibers are unlikely to grow by. And so when the fitness realm, where they're sort of working out, in a regular way, so that their sort of obesity, their fat in their body they're carrying is being lowered, so that their regrowth or their current symptoms are not being exacerbated and provoked. So this is a holistic approach that me, as an interventional radiologist, although I'm offering something that's minimally invasive, offering a woman a non-surgical alternative to a condition that has plagued women in the Bahamas, but also the fact that now when they regain their life, they can really regain their health and their wellness, which is my focus.
Right. So women like myself who may not be obese, however, we still have certain dietary restrictions, I assume, or, something that we can actually work on so that we can prevent fibroids from reoccurring or coming as sooner, I assume, than normal. What are some of the foods that you think can cause fibroids to return, if it's possible? And what are some foods that we can use to help, if this is also possible, eliminate or just not allow it to return ever again? Is that even possible?
Yeah. So again, if you have a garden, you bound have weeds. Right? If you got a garden, you bound have bees. Right. So that's just how it is. It's the nature. It's the nature. Right. So I can't say that you could do something that'll cause this to never occur again. So again, the genetic predisposition, the genes are the genes. Okay. So that'll occur. And we know historically that they go in an 8 to 15-year cycle. Right. So that's just how it is. And the only thing that prevents that is just hysterectomy, right? But we also know that tumors grow in an acidic environment. And so if you have an acidic environment, a pro-inflammatory environment, the tumors are likely to grow, and fibroid obviously being a tumor, okay? So what we then say is, all right, so if you create an internal environment that's pro-alkaline, it's an environment where it's less likely to grow, okay? So you are sort of not giving the genes an opportunity to express in sort of an exacerbated fashion. Okay, so things that promote estrogen, we know soy, we know flaxseed, we know dry fruit, we know garlic, we know peach. They're peaches. They all sort of are sort of estrogen secreting and producing.
Are you serious?
Yeah, phytoestrogen.
I put garlic and everything.
So time with that. So again, so these are things that obviously that are sort of estrogen stimulating and whatnot. So what we also know is that when you think about sort of, it's all about a balance. Okay. And there are certain things that allow you to sort of maintain that balance. So I spent the better half of yesterday at New Life, talking to one of my new collaborators.
Call him off organic. Go ahead.
And and one of the things that they do is they've sort of been treating women for years with fibroids. And I think what people don't think, it's not a mutually exclusive thing. It's a partnership, right? We're all in health together. And if you're in health together, you need to understand that there are realms of health, right? There's nutrition, there's fitness, and then of course there's Western medicine, right? And so within those realms, we need to make sure that we're optimizing all those realms. And so the nutrition, being able to have tonics that sort of promote the alkaline environment, being able to have a fitness regimen that promotes obviously fat reduction, and obviously controlling the sugars in your blood, ensuring that you're not taking products. They just showed that phthalates is one of those sort of endocrine disruptors. These are sort of toxins that we take in certain sort of household items, actually promote fibroid growth. And so eliminating all these things from our internal milieu will obviously help us manage this issue.
As we wrap up, there are two other questions that I have not forgotten, you ladies. I haven't forgotten, but since you're talking about nutrition, and one of the options that I was given last year prior to this final decision was to take this natural medicine. It's like a tea sort of. But of course, taking that, I think they say it will take about 6 months to a year in order to eliminate the fibroids or decrease the fibroids, based on this particular nutritionist, herbal lady. So what are your views on the natural remedies of eliminating fibroids?
So again, as I would have mentioned, there are tonics and things of that nature that promote an anti-inflammatory internal environment. But in the same way, that is fact. Okay. When I practice and I quote statistics to you, these are not statistics that I just threw out. These are statistics based on studies that I could print out and I could share with you. Okay. If someone says to you that this is going to eliminate something in 6 months to a year, first question I say, well, what is this based on? Is that just based on your sort of assessment, or, in the words of Ronald Reagan, you trust but verify, right? And so I'm a scientist. I may talk about dogs and ticks, I may talk about this and that, but I'm a scientist. Okay. So when I study and I, as serving the vice chair of the expert panel of the American College of Radiology, we're looking at data, right? In terms of what's appropriate and what's not. We're not just sort of looking at, I had a patient last week that had this experience. No. I'm taking all this data and these statistics and this evidence, and I'm translating it into a language where my patients could understand, and I'm using that in a very algorithmic way to manage my patients' issues in a way that seems as if it's understandable to that patient. And if it is, then I'm doing my job. When it comes to sort of obviously naturopaths, not every naturopath is created equally, right? And so you don't ever know what you're getting in terms of the tea, because you may not know what you're getting. There may be no study about this specific tea that you're getting for you to say, hey, this is going to have a 97% efficacy or a 60% efficacy for treating my bulk symptoms. You may not know that. And so I don't know of that sort of data. And so it's hard for me to comment on something like that in a very specific way. But what I can do is say that certainly the data surrounding certain natural tonics that have an anti-inflammatory pro-alkaline effect, they have a very, very studied effect on tumor growth, right? And so that's something that I can speak to as it relates to the women that we care for.
Okay. Does UFE affect your hormones such as LH, progesterone, etc., in any way, and if so, how?
Yeah. So as I mentioned, the specific hormone that we sort of think about when it comes to fibroids is estrogen, right? Because estrogen increases the fibroid growth, right? As I mentioned, estrogen is found in a number of places. It's found in ovaries, secreted by ovaries. It's found in the adrenal glands, which sit on top of the kidneys. It's also, the adrenal glands also produce cortisol and adrenaline, which is kind of fight or flight stress hormones. It's also found in fat. And certainly if you're pregnant, it's found in the placenta, okay? So we think about sort of estrogen being in the environment because of those things. As I talked about before, the fat piece is the piece that we want to sort of really sort of think about as it relates to the estrogen. There are sort of other things that people take in order to sort of quell the symptoms of fibroids, one of which is maybe progestogen or sort of kind of, contraceptives or having intrauterine devices of things that sort of alter the hormonal milieu. And that's something that's managed by gynecologists and obstetricians who are the experts in that. I'm not the expert on that. So those things obviously affect the fibroids because of the sort of hormonal regulation or dysregulation that may be occurring. And so those things affect. But when we sort of think about fibroids specifically, we're really sort of the actor that we want to zone in on is really on the estrogen.
Okay. Please also give us an idea of the cost of these procedures without insurance and with insurance. Is there a payment plan?
Yeah. So as I say, I don't deal with paperwork, right? So when you
smart man,
yeah.
Good answer.
Yeah. So when you talk to our team, and after if something's appropriate and you work with our team, they work with you. So
okay.
I stay out of the numbers.
So remember the lady that just had a UFE 3 weeks ago. A question is, how long after the procedure am I able to work out? I don't have any pain anymore.
Is this one of my patients? If this is one of my patients, then I would definitely talk to her. If she's somebody else's patient, I would certainly say she should talk to her doctor. Yeah. So, if somebody's under somebody else's care, it's like, talking to somebody else's wife and telling them what they should do,
right.
When they go out onto the bar, I don't make that mistake. So if somebody else is caring for that patient, I would say, I would kindly sort of, bow and say, you should definitely talk to your doctor. But certainly in the case of my patients, when I have my patients within the first week, there's restful recovery, and we have them, there's no driving, they're taking sort of medications up until the 7th day. And so they're just basically resting, and they're taking things, some scheduled, and others not. And then once they sort of stop taking those meds, I'm checking in with them every day, every other day. And then once they get to day 7, then we check in, and they're like, all right, man, I feel pretty good. And pain is like 1, 2 out of 10 maybe. And then now they say, okay, can I start working out? And I say, yeah, man, go ahead. And you start going working out, and we go incremental in the course of the second week. So between
the second
first
week, I was just about to ask. Okay.
So between the first weeks, after day 7, they finish all their meds, no more medications, nothing else. Then they go on to now the second week. And the second week is now when they're sort of incrementally getting back by the end of the second week to sort of, about 80% of what they were pre-procedure in terms of the regimen. And that is kind of they're going out, they're running errands, they're sort of getting sleep, and they're optimizing during that sort of second week. And then they're sort of walking if they go to walk, and then going to the gym, but they're really incrementally progressing. And after that second week, then they maintain that until they see me at sort of the first month. And when they hit the first month, and then the 4 to 6 week visit with me, then that's when we sort of have a conversation of where you're at, how you're working out. And then we then decide, okay, yeah, man, you should be in a position to really sort of step it up now in terms of to get back to 100%. And then they do that. And then we usually sort of, now what we're implementing is a detox for these women during the second, the sort of now between the first and second month now, so that they could really sort of re-engage and really kind of claim their life back and optimizing the nutrition and whatnot. And then we sort of go from there. And then I usually would see the women at the 5 to 6 month mark. We look at the MRI, and then at a year's time we sort of then hold hands and kumbaya and give hugs, and then we talk about our life over the past year and what it was and what it wasn't, and now what it's going to be. So
awesome.
Yeah.
Awesome.
So
awesome.
she wasn't one of your patients.
Oh, yeah.
No.
Otherwise she would know.
Yes,
Okay, there you go.
doctors.
There you go.
Dr. Higgins, you have been marvelous.
Oh,
Thank you so
kindly.
much.
Appreciate
We
it.
ran out of time. So, of course, there are always questions. And whenever you come back, just know that this show is available for you
Thank you.
to continue with, because there's so much more to discuss. But I tried to compound and try to fix everything into 1 hour and a half, hint. But you did, oh my God, I went a little over, but you've done everything that you possibly can in this time allotted to me, and I'm grateful for it. So thank you so much for your time. I want to know, how can persons reach you so that they can get additional information?
Yeah, thank you. So my team at Family Medicine Center are always at the ready, and they can certainly call in and self-refer, and they would certainly discuss what needs to happen in order to kind of get them to see me. And as we sort of talked about, making sure they have the initial screening and seeing one of our clinicians if they're not under the care of another clinician, and then they'll get them all teed up and ready to go. So yeah, just call Family Medicine Center on Blake Road, and we'll be happy to sort of connect them with me.
Awesome. There is one question that I had to ask. I have to ask before you go.
Of course.
How can you tell when the fibroids have gone back?
Oh yeah, so there's two ways. The first way is obviously symptoms, right?
You
so
go back to those same symptoms.
So once bitten, twice shy, right? If you know you've been bitten and you walked, in something before and you know what it smells like, you can check your shoe if you smell it again, right? So that's basically what it is. So a woman knows, right? So when if you have this, like the same woman who said that she was treated and they grew back, how did she know she grew back? Because the symptoms came back. There wasn't no panty liner anymore doing the job. Maybe now 3 or 4 or 5 or 6 packs. So you know. Yeah.
Okay.
Walks like a duck, quacks like a duck. Probably a duck.
Probably a duck.
Yeah.
All right. So thank you so much, Dr. Mikhail Higgins. You've been so good. You've helped us. You've answered questions. I can highly recommend it. My time is gone, so I can't even talk about my procedure and what I've experienced, but I can tell you that I'm a happy woman. My husband is a happy man.
Amen.
And
Amen.
I am just elated. I'm happy. I'm excited at the fact that I decided to go that way, that route.
Yes.
And it's phenomenal.
Awesome.
It was phenomenal.
I'm so happy.
All right. So today's show was brought to you by Airborne Freight and Cargo Services, John's Shoe Store and Accessories, Your Lane Life Coaching, Bahama Odds and Ends Party Supplies, Johnson & Johnson, distributed by Lowe's Wholesale, Carey's Fabric and Uniform Store, and Dairy Queen. Carey's Fabric and Uniform Store is stocked with uniform fabrics and ready-made school uniforms for almost every school in the Bahamas. At Carey's, you can find uniform skirts, jumpers, shirts, blouses, pants, shorts, underwear, and school supplies. You can get your skirts custom made, and you can shop at Carey's Fabric and Uniform Store on Mackey Street. Shop early and save. And the number to call there is 393-0758. Just a reminder for you, for Dairy Queen fans, if you buy a blizzard, and you can make miracles happen. Join DQ this Thursday, July 27th, for Miracle Treat Day at Dairy Queen, all locations nationwide. For every blizzard treat or coupon purchase, you will donate, or they will donate $2 to the Bahamas Kidney Foundation. Dairy Queen, together, let's make a difference for those in need. Now, if you need coaching in any area of your life, you notice I didn't have time to talk to the audience. What could I possibly talk about with talk to the audience? We have a doctor right there that can tell you everything, right? So, but if by chance you need coaching in your life, including premarital coaching, knowing how to restore your marriage, etc., how to stand, even when you feel abandoned, or how to build a relationship, please go to my website, www.yourlanelifecoaching.com. I am just an advocate for strong marriages. And before we even get to the point, before you get married and say I do, Dr. Higgins, are you married?
Not.
Okay, well, you need to come see me for your premarital coaching, please, sir. I would be happy to help you improve your life and your relationship. www.yourlanelifecoaching.com. So I want to thank each and every one of you for listening, for tuning in, those on Facebook that asked those questions, those who have been listening via cable and also via radio. Thank you so much. Star 106 FM has been phenomenal, as always, ensuring that this show has been done and you can hear everything professionally sound. Next week, real quick, let me just say we will have with us in studio Dr. Nina Graham. Hello. What's really going on down there? That's the topic. Down there, yes, that's the name of the show. What's really going on down there? Everything pertaining to our lady parts. I promise you, down south, listen, if you have a problem or squeamish in any way about the different things pertaining to our lady parts, don't listen. Tony say I ain't gonna be here next week. Let me put my Baptist finger up now. All right, feminine sense, grooming and proper hygiene, menstruation, types of products to use, etc. We need to know how to keep it. We need to know how to keep this. we need this, right? This is where our babies come from. This is how we get to have the babies. This is how we, eliminate things and stuff from our bodies. So you want to make sure keep it in its proper state and as healthy as possible. So we have Dr. Graham on and in and ready. She ready. Like she wanted to come today ready. All right. So thanks to my producer, Tony. Thank you to my Facebook audience. Thank you for Odessa for always being here and present. Our continued listening audience and our first-time listeners, welcome and thank you so much for joining us today. Please follow the page Your Lane Life Coaching to get all of the updates and goodies from the show. And you can go to your Coach Trish Hanna on YouTube to watch the previous shows. Please like and subscribe. I pray that you all were empowered, educated, and encouraged today. Until next time, happy Sunday.
Great job.
Off Facebook. Yes. Thank you, everyone.